Good evening, everyone. I'm Eunice. I work in the Department of Hematology, and I thank the organizers for giving me this opportunity to share about this iron in health and disease. So my talk basically will be covering on iron metabolism, how the regulation of iron happens, and what happens when this homeostasis is dysregulated. And then I'll be going into different iron-related disorders with case histories, both mainly concentrating on primary and some amount of secondary iron overload. And I'll be talking about iron in other disorders. So, as we all know, iron is the most second abundant element in the planet, and it has an important role in the body. So, initially thought it's a main component of hematopoiesis alone, but with studies, it's been known that many enzymes like cytochrome P450 families and ATP production, and also immune system requires iron. So this picture shows the role of iron in various tissues, which like myoglobin in the muscle, which helps in oxygen storage and release, in infections, because we know iron is an important nutrient for the pathogens. And recently many studies have shown that iron also plays a major role in immunity by helping in T cell development, in eosinophil peroxidase, which is for the function of eosinophil peroxidase to combat parasites. And it also been known that the M1, M2 polarization in macrophages is also influenced by iron, and also the bactericidal activity of neutrophils is also modulated by iron, in addition to red blood synthesis, which is the major function of the iron. And it is also known that neural development is dependent on iron. Yeah, how is this? If you look at the distribution of iron in humans, we have around 3 to 4 grams of iron. And as I said, most of the iron is in the red blood cells, and some amount of iron is stored in the liver, and there is some amount of iron in the muscles, and around 3 milligram remains in the circulation. And we know that about 1 milligram of iron is absorbed from the diet daily. How is this iron absorbed and utilized? So as we all know, the dietary iron is in the form of Fe3 plus in the non-heme iron form. This Fe3 plus is getting converted by the enterocyte duodenal cytochrome B to Fe2 plus. This Fe2 plus is then transported into the enterocyte via the Divalent Metal Transporter 1. So once it is inside the enterocyte, it can follow two paths. It can be either exported out, or it can be stored as ferritin in the mucosal, in the enterocyte. The same way, the animal proteins contain a lot of heme iron. This heme iron can be transported via the enterocyte using a molecule called heme transporter, which is known as the heme carrier protein. So this heme iron is also opened up, and the iron is then transported through the only known iron exporter, ferroportin. So once this iron comes out from the enterocyte, it has to be converted to Fe3 plus, because the iron carrier protein in the circulation is transferrin, which can bind only Fe3 plus. So this is done with the help of heptastin, which is present in the basolateral membrane of the enterocyte, which converts this Fe2 plus to Fe3 plus. And this Fe3 plus is then taken up by the plasma transferrin, which is then taken to various tissues. So how is this transferrin taken up by other tissues? So the main user of this transferrin bound iron is the bone marrow, where it is used for mainly the RBC production. So what happens is this transferrin bound iron is endocytosed, and then once it is inside the endocytose, this is then converted. The acidic medium releases the Fe3 plus from the transferrin, and then this is converted to Fe2 plus via STEAP3, and then this is transported by DMT1, and this Fe2 plus is then used for heme synthesis, which is then incorporated into the hemoglobin. And in the liver, when it is taken up by same transferrin receptors, and then it's mainly used as the storage site. And we know that when the lifespan of RBC is 120 days. So after this 120 days is over, this RBCs are taken up by the reticuloendothelial system, where they are ingested, and this hemoglobin is processed, and the heme iron, the iron is released, and this is then transported out by ferroportin into the circulation. And we have around 20 to 25 milligram of iron released from the reticuloendothelial system every day. So how is this iron regulated? Iron regulation is a one-way regulation. What I mean to say is iron is regulated only at the absorption stage, because it cannot be controlled at the iron excretory stage. And iron regulation can happen at the cellular level through various mechanisms and at the systemic level. So both the cellular and systemic iron regulation mainly happens through the hepcidin ferroportin axis. And now we will see the cellular and the systemic iron metabolism, how they are regulated. Cellular iron homeostasis is mainly controlled by the IRE-IRP pathway. So we know that when there is low iron, this IRP1 and IRP2 bind to various mRNAs. So when there is low iron, the mRNAs involved in iron homeostasis proteins have a IRE element. This can be present in either the 5' end of the mRNA or at the 3' end of the mRNA. So what happens is when this IRP binds to the 5' end of the mRNA, wherever this mRNA has a 5' end IRE, so they inhibit the translation of the protein. And when it binds to the 3' end of the mRNA, these mRNAs are stabilized and leads to increased production of protein. So the mRNAs which are involved in iron storage and heme synthesis and iron export have IREs at the 5' end, so that when iron is low, iron storage and other things are down-regulated. Whereas the iron intake proteins like transferrin receptor 1, DMT1 and other proteins are upregulated by increased protein synthesis. And iron homeostasis at the cellular level can also be regulated by oxygen levels. So when there is low oxygen level, as we know, hypoxia inducible factor alpha and beta, they are stabilized and they dimerize and they translocate to the nucleus and they upregulate the transcription of various hypoxia induced genes. So these are involved in iron uptake as well as iron transport. So when there is high or normal oxygen, proline hydroxylases degrade this HIF alpha proteins, so they do not induce the expression of these genes. So this is how cellular iron is maintained. Systemically, hepcidin is the known like a central regulator of iron homeostasis. So what happens when there is high levels of iron? So transferrin receptor 1 is the main iron receptor, but there are transferrin receptor 2. When the transferrin receptor 1 gets saturated, the iron binds to transferrin receptor 2 also. It's mainly in the liver. So what happens when iron binds to the dipheric transferrin binds to transferrin receptor 2, HFE binds to TFR2, and they stimulate the SMAD signaling pathway, which in turn goes into the nucleus and induces the expression of hepcidin. The other way is through the BMP6 and BMP2 signaling. So it is not clearly understood how this increased iron induces this BMP, but these BMP molecules bind to the BMP receptor, and hemojuvelin is a cofactor for these receptors, and they stimulate the same SMAD pathway and then lead to the hepcidin production. So this figure shows what are all the various scenarios where hepcidin can be induced or inhibited. So as we know, iron stores increase hepcidin synthesis, BMP signaling, infections or inflammation can also increase hepcidin synthesis. Whereas erythropoietic demand, hypoxia and endocrine regulation, which all are requiring increased iron, so they all inhibit hepcidin synthesis. And hepcidin mainly acts via ferroportin, which is the only known exporter of iron. So hepcidin binds to ferroportin and internalizes ferroportin, thereby inhibiting iron egress from the cell. So this is again a regulation of hepcidin. As I told, when hepcidin binds to ferroportin, this internalization and degradation of ferroportin, so there is less amount of iron in the circulation. So this can happen in iron overload, inflammation, when there is hemolysis, and when there is, recently it's been said that if people with increased adipose tissue who have increased BMI have increased hepcidin production, and transfusions and some genetic variants can also cause increased hepcidin production, which leads to internalization of ferroportin, leading to decreased iron in the circulation. Whereas contrary to that one, anemia, iron deficiency, hypoxia and erythropoiesis inhibit hepcidin through various factors. So there is increased iron in the circulation for utilization. So what happens when this balance is lost? So iron is homeostasis is a very fine-tuned mechanism with a fine balance which regulates between deficiency and iron overload. So what happens in iron deficiency when there is decreased iron? So there is decreased iron in the circulation, and so there is less storage and there is less iron for erythropoiesis. On the other hand, when there is increased iron, so you have a lot of iron for storage. So your hepatocyte is loaded with ferritin and your macrophages, and there is increased iron available for erythropoiesis. So the first which we will be seeing is iron deficiency anemia, and we know that in India it's one of the most common public health issues where more than 50% of pregnant women and even in males and adolescents, the iron deficiency anemia is one of the main causes of anemia. So here we can see that iron deficiency anemia can be physiological during infancy, adolescence and pregnancy where there is increased iron demands, and it can be due to inadequate intake, which can be due to poor nutrition and vegetarians which who do not take animal products. And the other reason is decreased absorption. It can be due to a celiac disease or gastritis or various reasons. And the other reason is chronic blood loss. It can be a menstrual, GI tract or any other blood loss. So if you look at pathological disorders which are associated with iron deficiency anemia, we know that several neoplasms contribute to in the digestive tract. If there is hematuria and hypochlorhydria or achlorhydria, where acid production. So acid is very important for iron absorption, and dietary. When you take a lot of tea and coffee which contains flavonoids and phytates which can chelate iron, and other diseases which can cause iron deficiency anemia. So this is one of the recent guidelines for diagnosis of iron deficiency anemia. Previously, it has been with soluble transferrin receptors and other things. Now, what people are suggesting is to go with serum ferritin and CRP. So, if you do a full blood count with serum ferritin and CRP, you can have three scenarios. So, one is anemia. So, anemia is described as hemoglobin less than 13 in males and in less than 12 in non-pregnant females. So, if there is no inflammatory disease with a normal CRP, if you have ferritin less than 15, it suggests iron deficiency anemia. And if you have a normal CRP and ferritin more than 50, the incidence of iron deficiency is highly unlikely. And in the presence of CRP, if you have ferritin less than 15, it's clearly iron deficiency anemia along with the inflammatory disease. But the levels of ferritin to call iron deficiency in conditions of inflammations or infections, they go up to ferritin 150. And if it is ferritin more than 150, iron deficiency is unlikely. And if there is no anemia, but you have ferritin less than 50, it may be a earlier stage where you have iron deficient erythropoiesis can happen, and your investigation into iron deficiency may still be required. So I'll be talking a little bit about iron refractory iron deficiency anemia. Initially, people thought this iron refractory iron deficiency anemia or response to iron supplements is mainly due to compliance and dietary factors, but there are several important causes for iron refractory iron deficiency. So how do you define iron refractory anemia? So it is a failure to respond to oral iron treatment with 100 milligram of elemental iron for 4 to 6 weeks with at least an increase of 1 gram per deciliter. So the common causes should be ruled out before we suspect a case of IRIDA. So like H. pylori by doing antibodies or urease breath test or TTG for celiac disease and antiparietal antibodies. So if all these are negative and you do not have a reason for iron refractoriness, then we can go for genetic cause of IRIDA based on this history and clinical assessment, where TMPRSS6 can be sequenced to identify the genetic defect. So this was the first paper which came in 2008, which described a series of iron refractory iron deficiency anemia due to genetic variants present in this gene. And this is the first paper which had a genetic cause for iron deficiency anemia, where they had reported 7 cases. So if we look at these cases, they all had low hemoglobin and the MCV was very low, and transferrin saturation also very low, and they all had mutations in the TMPRSS6 gene. And so what does this TMPRSS6 do? How is this contributing to iron refractoriness? TMPRSS6 is a transmembrane proteinase. So what happens is this TMPRSS6 acts on this hemojuvelin and cuts the hemojuvelin. As I told earlier, this hemojuvelin needs to bind to the PMP for the SMAD signaling to happen and decrease the production of hepcidin mRNA synthesis. So what happens is, if this hemojuvelin is cleaved, the negative regulation of TMPRSS6 is that function is gone. So when TMPRSS6 is not able to cleave this thing, so there is a constant expression of activation of this MAC complex, which leads to increased hepcidin synthesis. So increased hepcidin synthesis leads to decreased serum iron, resulting in iron refractory iron deficiency anemia. So this was our first case which we had seen in our department. This was a 35-year-old female. She had 2 pregnancies which she went through with transfusions and to maintain her hemoglobin. When she presented, she had a hemoglobin of 6.6 and MCV of 54.5, And if you look at the ferritin was always on the low level, like, it was not below 15, but it was always on the borderline, like 20. And when we checked the hepcidin level, she had high hepcidin levels. And that time, this paper had come, so we also, went ahead with the genetic screening of this TMPRSS6 gene, and we found out that she was homozygous for this mutation in the TMPRSS6 gene, which explained her phenotype. So when we analyzed her children, they both were heterozygous for this mutation. So they did not have a clinical phenotype, but they had mild reduction in the MCV and other parameters. So after that, we have seen another 3 more cases of iron refractory iron deficiency anemia. These like 2 from one family from Andhra and 1 from Kerala. So if you look at all these cases, the hemoglobin levels are much lower, and the MCV is also very, very less. All of them are below 60. And if you look at iron and TABC, they are kind of, in the low. TABC is normal. And ferritin is kind of in the, we could do hepcidin only for this case, which showed a higher levels, whereas hepcidin levels were not. So when we did the genetic analysis, we identified that all 3 of them had a mutation in the TMPRSS6 gene, which explained the phenotype of this iron refractory iron deficiency anemia. So iron deficiency is one spectrum. Iron overload is the other spectrum of iron metabolism. So in normal conditions, iron stores in the liver and absorption are regulated by hepcidin. When there are genetic defects which lead to decreased hepcidin, there is increased absorption of iron from the duodenum, which leads to increased iron in the circulation and increased deposition in the liver. So you have increased iron overload. So how do we, when to suspect hemochromatosis? So in hemochromatosis diagnosis, transferrin saturation is the mainstay for suspicion of hemochromatosis. So it should be more than 45% is the first step in the working algorithm for hemochromatosis. And then serum ferritin more than 200 in females and more than 300 in males. And if we can do liver MRI for iron overload and or a biopsy of the liver to see iron deposits, these can be additional things. So other things are clinical evaluation can show skin pigmentation and arthritis and other things which can help us to suspect hemochromatosis. Initially, hemochromatosis was classified like this based as type 1, type 2A, 2B and other things based on the 5 main genes which are involved in iron homeostasis. So now recently it's been the working group of the hemochromatosis has reclassified hemochromatosis into 4 different groups. So it is HFE related. So if you have a mutation in the HFE gene, then it is HFE related hemochromatosis. This has a low penetrance and it presents mainly in later life, whereas the non-HFE related, where hemojuvelin, hepcidin, transferrin receptor 2 and ferroportin, a gain of function mutation, can lead to, these are rare variants, but they can lead to a severe phenotype. Most of these patients present earlier in life and have a severe phenotype as compared to the HFE hemochromatosis. And you can have a digenic also, where you can have a heterozygous mutation in one gene and in one other gene, but that is very rare. And we still have cases where We do not know the molecular reason for why they have iron overload in spite of screening for all the known iron metabolism genes. So this is the new classification where it's classified based on the gene involved, HFE and non-HFE, and molecularly undefined. So this is one diagram where based on the transferrin saturated and ferritin levels, so this is mainly because this primary hemochromatosis is mainly in the Caucasian population, they advise to go for directly the HFE, and C2A2Y is the most common mutation in the HFE. So if that is homozygous, then you can label it as HFE related hemochromatosis. And if it is not there, then you can go for other genes in other non-HFE related genes, and then we can classify them based on the genetic findings. So do we see hemochromatosis in India? Because most of us talk about iron deficiency anemia, and that is seen as the more common one. But if you try to look at in the picture of X, if you see closely, we can see. So similarly, we do have cases of hemochromatosis which are reported in the Indian population, but it is rare, and it has been reported in 5 related genes. So in our hospital, we had done a study of 42 unrelated Indian patients who had suspected hemochromatosis. These they mainly present to the hepatology department and endocrinology department with liver iron overload, and usually in the endocrinology for diabetes and hypogonadotrophic hypogonadism. So this interestingly, we found the C2A2Y in the HFE gene in a family from Andhra Pradesh, and we have also seen cases with hemojuvelin and AMP mutations. So this is the family of hemochromatosis with C2A2Y mutation. So this is a family from Andhra with 5 siblings. The elder sibling had died before they come due to liver disease. So if you see, they all presented at the later stage in life, and their transferrin saturation was much higher with high ferritin levels, and we found out that this C2A2I haplotype is similar to the European haplotype, indicating that this mutation has come through population migration. So this is one family which we reported in the later life, which presented to us, and there has been 1 or 2 reports after this for C2A2I heterozygous state. But this is very rare in our population. So when we did not find mutations in HFE in the other patients, then we looked for the other 4 genes, non-HFE hemochromatosis genes. So if you see, they all present early in life, and this population is from South India as well as from North India. So there is no geographical location for this non-HFE hemochromatosis. So all their transferrin saturation levels were much higher, and serum ferritin was very high, and we could identify 4 mutations in HFE2. This is the hemojuvelin gene, and 3 patients with hepcidin gene mutations. And if you look at most of them, all of them were either a frame shift or a nonsense mutation. So we looked at iron deficiency, we looked at iron overload. There is a group of diseases related to iron which are called as iron loading anemias. So what is called as iron loading anemia? The definition is it can encompass as a group of inherited and acquired anemias which are characterized by ineffective erythropoiesis, low hepcidin, and because of the low hepcidin, there is excessive iron absorption and secondary iron overload. So what are all the anemias which are characterized by ineffective erythropoiesis, which can be classified under iron loading anemias. So all thalassemias, where non-transfusion dependent thalassemias, where we know that there is decreased hepcidin levels and increased iron absorption, and congenital dyserythropoietic anemias, sideroblastic anemias, hemolytic anemias, and other acquired disorders like MDS and related diseases. So these are all classified as iron loading anemia. So what happens in this iron loading anemia? Why is there iron overload when there is anemia? So when there is anemia, there is increased erythropoietin production and there is increased erythropoiesis. So when erythropoiesis is increased, there is release of GDF15 and TWSG1. These were initially known to suppress hepcidin, but recently it's been identified that erythroferrone, which is also released during erythropoiesis, is the major factor in inhibiting the hepcidin mRNA. So when there is increased erythropoiesis, this erythroferrone is released, which inhibits hepcidin. So when hepcidin is inhibited, you have increased iron absorption, leading to increased iron in the circulation. And as we see from the situation, the erythropoietic regulation of iron overrules the store regulator. So, sideroblastic anemia. So, how do we look at sideroblastic anemia? So, based on the ring sideroblast, so there is iron deposition in the mitochondria, which give rise to the ring sideroblast. So, initially we had screened the 3 cases with suspected sideroblastic anemia, and they all had low hemoglobin, MCV was low, and we could identify mutations in the 2 genes, ALS2 and SLC25A38. So this sideroblastic anemia is commonly, it can be either X-linked or autosomal recessive. So we found out that contrary to what is in the literature, we found out that most of our sideroblastic anemia cases are autosomal recessive, and more than 55% of them had mutations in the SLC25A38 gene, which is associated with sideroblastic anemia. And ALAS2 gene mutations were identified only in 30% of the cases. So the ALAS2 is the X-linked sideroblastic anemia, whereas this SLC25A38 is a autosomal recessive form of sideroblastic anemia. So here also we had some cases where we could not identify the genetic defect. So in addition to increased erythropoiesis, we have some other, due to defective iron proteins, we can have anemias with iron overload, but these are not due to ineffective erythropoiesis. So one such example is atransferrinemia or hypotransferrinemia. It is actually an extremely rare autosomal recessive disease because so far only 14 to 15 cases have been reported in the literature, and only few have been characterized at the molecular level. So how to diagnose atransferrinemia? So they have a clinical picture similar to thalassemia. Their hemoglobin is less, MCV is less, with high ferritin requiring transfusion. So the basic one will differentiate this. If you do a iron and TABC, the TABC, because the transferrin is not there, will be very less as compared to a thalassemia or a normal individual. So TABC may be the indicator to identify atransferrinemia or hypotransferrinemia. So we had 2 children which we identified. So one had been treated as thalassemia outside, but when they came to us, we because she was transfusion dependent, then we could do the different test, and we identified that she had a transferrin gene mutations, and these children benefit from plasma transfusions. So one another protein which can lead to anemia and iron overload is ceruloplasminemia, aceruloplasminemia. It's an autosomal recessive disorder. But here you can easily suspect aceruloplasminemia if they have anemia, iron overload, and they will also have neurological symptoms. And serum ferritin will be markedly elevated, and you can around 60 patients with aceruloplasminemia have been reported. So this is one case where it was a 9-year-old male who had neurological deficiencies, and he had moderate anemia with hemoglobin of 8.3, and MCV was very less. And when you look at the transferrin saturation, it was only 3%. And when we did the ceruloplasmin, we found out that it was nil, and we could identify the mutation in the ceruloplasmin gene. So, in addition to inherited iron, with recent research into various different systems, it has been identified that iron plays a major role in neurodegenerative disorders. And we know that this is the most abundant transmission metal in the brain, and it sustains the brain's respiratory activity, and it is used for myelinogenesis and production of various neurotransmitters. And as we all know, iron deficiency in young children can impair cognition, and because it's used for brain development. Iron is an important for brain development. And iron overload or pathological deposition of the iron has been associated with many neurodegenerative disorders. So there are a group of disorders known as neurodegeneration with brain iron accumulation. One is aceruloplasminemia. These are the genetic causes. Aceruloplasminemia can impair astrocyte iron export and uptake by neurons, so leading to iron accumulation. This is also one of the neurodegenerative disorders. Neuroferritinopathy, where if you have mutation in the ferritin light chain, the iron cannot be stored as ferritin, so it leads to increased iron in the cell, leading to iron-mediated oxidative damage. And a mutation in frataxin, a mitochondrial chaperone, which is required for the iron-sulfur cluster assembly and heme biosynthesis, can lead to alteration in mitochondrial iron storage and lead to neural degeneration. And these are genetic disease which we saw, but now studies have shown that iron is also associated with common neurodegenerative diseases like Parkinson's and Alzheimer's. But it's still not very clear whether the iron accumulation leads to pathogenesis, or the iron accumulation is a result of the pathogenesis. But a functional iron responsive element has been described in the 5-UTR of amyloid precursor protein, and also in the alpha synuclein, which are proteins which are essential for neural function. And alterations of other iron homeostasis proteins like transferrin receptors and others have led to iron accumulation, have been reported in Parkinson's disease patients. And lot has been studied in about iron and cancer, and people with hemochromatosis have an increased risk of hepatocellular carcinoma, because we know that iron is a pro-oxidant and can damage DNA and then promote oncogenesis. And second, we know that cancer cells have an enhanced dependence on iron to maintain their rapid growth rate. And various cancers like in breast cancers and adenocarcinomas and other things, there have been studies which show that there is altered expression of iron homeostasis proteins, so that the cancer cells, even though they have enough iron, they have they have a increased TFR1, decreased ferroportin, which mimics a iron deficient cell. So thereby they keep on taking more iron, and it is useful for their survival. and several gene expressions of iron-related proteins have been associated with survival. And chelating iron has been used to promote oxidative stress, to which cancer cells are particularly vulnerable. So this is some table which shows, this is a very kind of a busy table, but it shows that the expression of transferrin receptor, which is high in breast cancer patients, in various esophageal, colon and ovarian lung tumors, transferrin receptor to DMT1. Usually it is overexpression is seen in tumors associated with metastasis. And ferroportin and duodenal cytochrome B, and even the iron regulatory proteins have also been, their expression have also been dysregulated, and it helps in the cancer cell progression. Ferroptosis is one of the newer terms which has been in the iron field now. So what is ferroptosis? It's a new form of cell death that results from iron accumulation and lipid peroxidation in cells. So it is morphologically and mechanistically distinct from other cell death mechanisms like apoptosis, necrotosis and autophagy. So why is it known as ferroptosis? Because it's an iron-dependent oxidative damage involving changes like decreased mitochondrial cristae and damaged mitochondrial membrane. So what happens is, when there is which is through the glutamate cysteine antiporter system. So this elastin inhibits this system. So there is decreased production of GSH, which is an antioxidant, and which leads to increased lipid peroxidation, which leads to cell death due to increased production of lipid peroxides. So it has been now people are trying to inhibit this ferroptosis, or which is the cancer cells have various mechanisms to avoid this ferroptosis. So studies are being conducted to see whether they can induce ferroptosis by modulating iron levels, and which can be used in cancer treatment. So the last part which I would like to say is, iron has a major role in immunity and infection. So as I said before, pathogenic microorganisms require iron for survival and proliferation. And the hepcidin ferroportin system in humans, they restrict iron availability in the context of infection, because bacteria need iron. The system, body has a system by withholding iron by increasing hepcidin levels. And the effect of iron deficiency in protection against malaria and diarrheal illnesses have been reported. So in case of infections, the iron regulation can happen in two ways. If it is an extracellular bacteria, the hepcidin, the regulation of iron is that it prevents the release of iron from the cell, so that the bacteria cannot use the iron. In case of intracellular bacteria, the cytokines, the hepcidin and other molecules induce the expression of cytokines and other things, which increases the phagolysosome, so that the intracellular bacteria are killed and iron is released into the circulation. And it has also been, family has been reported with 8 siblings to have mutations in the transferrin receptor gene, which resulted in immunodeficiency. This was a case, a group of patients from Saudi, where they have identified that transferrin receptor mutation has resulted in immunodeficiency in the cohort. So as we see now, that iron cycle is very tightly regulated between absorption and what is utilization, and alterations of systemic iron homeostasis can be caused by imbalances either by dietary or inflammation or genetic aberrations or thing, which affects the hepcidin ferroportin regulatory system and results in either anemia or iron overload. Thank you.